everyone. Thank you so much for being here and for joining us. This is a leadership exchange, which is a program of the Well Project. Normally, these are not had to be done live. We are talking about HIV and menopause and women. And as I'm sure all of you know, the information that's out there is either scattered, there's not enough, we're confused about it. And today, we are hoping to clear some of that up. And I am super excited at the guests that I have with us today. I'm going to allow them to introduce themselves, and then we're just going to jump right in because I want to spend as much time as we can talking about this very important topic. So I am Bridgette Picou. I am a nurse and a woman living with HIV. I have been living with it for the last 11 years, which is this year, just for whatever reason, things seemed a little bit different. And I think maybe that's because I'm turning 51 and really in that stage where menopause is going to start to become an issue. I'm the Stakeholder Liaison for the Well Project. And part of what I do is bridging the gap between women living with HIV and clinicians. And we have two amazing clinicians here today, along with our longtime collaborator, the amazing Miss Gina Brown. So, Sara L, why don't we go ahead and start with you and let you introduce yourself?
Great. Thank you so much. And thank you for inviting me to present today. This is such an honor, and I am just eternally grateful and feel so valued to be able to educate this community along with my colleague, Sara B. My name is Sara Looby, and I am a nurse practitioner by training, and I also have a PhD in nursing. I work at Massachusetts General Hospital and a special division in the endocrine unit that looks at cardiometabolic, so heart and weight related issues in people with HIV across the lifespan. And for the past, I would say, 13 years, my area of expertise through research has been exploring menopause in women with HIV, particularly looking at symptom management, age of onset of menopause, and also partnering with women with HIV from the community to learn about what they're experiencing with reproductive aging and to use these valuable insights from those experts to help inform my research. Thank you.
Amazing. Thank you for being here. And Sara B.
Yeah, thank you so much. And I will echo Sara Luby's comments. Just thank you so much for the invitation and thank you for all the work that you do, all the advocacy and education. We're really grateful for you and grateful to be here. My name is Sara H Bares. I am a infectious diseases physician and I'm based in Omaha, Nebraska, which is in the middle of the country. I did not grow up here, didn't know where it was, had to find it on the map before moving here. But I am based at the University of Nebraska Medical Center, and I have a mix of responsibilities here. I care for patients with HIV in clinic a few times a week, and I teach and I do research specifically interested in HIV clinical research with a special interest in the metabolic complications of HIV, HIV and aging, and HIV in women, and also like Sara Looby have a special interest in HIV and menopause.
Awesome. Thank you so much for being here. Gina Brown, reintroduce yourself.
Hello, family and friends. Gina Brown. I'm a woman living with HIV 29 years. It'll be 30 years in April. I tell everybody I'm an activist by birth and a social worker by training. Been a part of this community a long time. Love the community, love the Well Project. And yes, I have been having this conversation about menopause a long time because we don't talk about it. And all I know is sometimes I have to pull out the fan and I didn't know why. So I'm so glad we're having this conversation. So thank you, Bridgette, for the invitation.
Absolutely. Absolutely. And like I said, I want to jump right in so that we can really have an in-depth conversation and maybe try to answer some things that have been missing. And Gina, like you just said, we really don't talk about menopause. It's always the elephant in the room. And so the first question is, can we talk about what menopause is and what menopause isn't? Because I think sometimes there's confusion about that too.
Yeah, I'm happy to start, and Sara, you can chime in if I forget anything. So, I'm so glad that we're talking about menopause, because you're right, we don't talk about it enough. And I think the more we talk about it, the more we can understand and destigmatize menopause. And so just to break it down a little bit, the word menopause actually comes from the Greek words mens for month and pausis for cessation. So it's the cessation of the monthly menses. It marks the end of menstruation, and it's considered to have occurred after a woman has gone a full 12 months without a period. So that's menopause. But menopause is not just one point in time. It's a period, and it's a period of many years, actually. So the time leading up to that last, the 12 months after your last period is just as important as the time that menopause, and then the time after menopause or post-menopause. And so the time leading up to the last period is called the perimenopausal period, or in medical terms, the menopausal transition. It usually begins about 4 years, but up to 10 years before menopause. And it's during this transition that we begin to experience symptoms. And some of the most classic symptoms, the real hallmark symptom of the transition, is hot flashes. So Gina brought her fan, and that's exactly right. It's not just a myth. It's not just what we talk about. It is the predominant symptom of menopause, the most bothersome symptom, and it can affect a lot of different areas. That's what menopause is. I think it's important to note that it's not pathological. It's not an illness. It's although the symptoms can cause distress and significantly impact our daily lives and result in missed work or other side effects, it's not a disease. It's a natural process.
And I would just add what menopause isn't. It is not the end of our life. It is not the end of our sex life. It is not the end of any of those things. For me, and y'all know I like to use I statements. It has been, other than the hot flashes, it has been really liberating, not to worry about, I can't wear white pants at this time because my cycle might come. Or if I'm out traveling somewhere and I forgot to pack tampons, how am I going to get them? I've been so embarrassed going to the front desk and the guy's there instead of the woman who I checked in with and saying, do y'all have any tampons? And then dropping my head, So it has been all of those things to me. But more than anything, it's been that elephant in the room that no one was talking about. I remember the first time I got on a plane and I had a hot flash. I didn't even know what it was. All I know is I started sweating and I got so embarrassed because it wasn't hot. And I didn't know what was going on. And this lady, she patted my hand and she said, you're going to be okay. And I probably had a look like, what is going on? But I didn't know.
I think that's a really good and important point, is because sometimes we don't know what it is or what to expect from it. And I think we often forget, and I'm glad you brought that into this. I think we often forget that it can be liberating for women in a lot of ways. For some reason, menopause is perceived as being this negative experience. And I hope that some of this conversation steers us away from that negative way of thinking about it. Let's see, we do have another question here. And are the needs of women living with HIV different when it comes to menopause? Are there differences that we can expect as opposed to the general population?
Thank you so much, Bridgette. I'll take this question, and I'm going to respond to this question, which is sort of broad, by starting with a story that I think is very relatable. And so, when I was working as a nurse practitioner about 13 years ago, a woman with HIV came in to see me for a visit for a research study. And she asked me, she was in her mid 40s, and she asked me how she could tell if the night sweats that she had just began to experience, if whether these night sweats were related to a low CD4 cell count and a high HIV viral load, or menopause. And In fact, this new onset of night sweats absolutely terrified her. Having lived 15 years with stable HIV and on medicine, she was now concerned that her HIV medicines were no longer working, and now she had AIDS or an associated complication. And she was paralyzed with fear. And so when she told me that story, it was really when I began to learn from the women that with HIV that there is distinct overlap between some of the symptoms of menopause that are commonly experienced among women without HIV and are associated with the loss of estrogen, which is the hormone that we lose as women when we enter menopause, which stops our periods from happening, etc. And some of these symptoms, as Sara mentioned, are hot flashes, mood swings, problems sleeping, okay, um, a lot of anxiety in particular, some forgetfulness or going into a room and being like, why did I come in here? Or a hard time processing very quickly when you might have been feeling a little sharper. And so those are sort of traditional symptoms of menopause and estrogen loss that we see among all women. But when you think about symptoms that are commonly observed in HIV, night sweats, sleep problems, anxiety, um, processing changes, particularly with aging, you can see that there could be a very difficult time distinguishing the difference between the two when you are a woman with HIV who is encountering or entering midlife and menopause. And so after that visit, I went back to my office and I was looking online to see if I could find any research articles, and I really couldn't find much. But I actually found an article that was published in Positively Aware, so a consumer-driven newsletter. And the quote from that was a woman that said it was called Hell in a Hot Flash. And this woman shared a very similar story in which she said in the quote that after a week of waking up in the middle of the night with drenching sweats, I ran to my doctor in a panic, reminiscent of the day when my T cell count, CD4 count, was 8. And I just knew something was wrong with me. And so I think when we ask about the differences and what are the needs in women with HIV and without HIV, I think I basically break those down into 3 domains: educational needs, psychosocial needs, and physical health needs. Education first and foremost, and I know, we'll probably talk about this, but when you mentioned, Gina, talking about menopause, what is menopause, is very taboo in certain cultures, in certain families. We don't talk about women's problems. We don't talk about women's health. Also, women with HIV, I'm preaching to the choir here, if you will, experience disproportional rates of trauma in certain settings compared to women without HIV. So, for example, talking about their first period can be challenging. Maybe they didn't have a primary female caregiver that they could share and learn about menopause with, a history of teen pregnancy, a history of a traumatic sexual encounter, rape, domestic violence, all of these things. So, thinking about or having comfort with asking about what menopause is can sometimes be a challenge because it brings back or triggers a lot of trauma. So we find that in general, at least I find, and I'm sure Sara finds, and what we have encountered through our community forums, that there really is a knowledge deficit about what menopause is and how it differs from pregnancy, how it differs from your first period. A lot of people just think they're going crazy and it's only happening to them, but menopause happens to all women who have a uterus and ovaries, born female, um, and unless they've had surgical menopause and others. So just getting education around what it is, why it's happening to you, how long it lasts, what the symptoms are first. Second, when we talk about psychosocial needs, I touched on the trauma a little bit. We know that mood swings are common in menopause, particularly because estrogen binds to a chemical called serotonin, which is kind of like a piece of Velcro on some of our brain cells that helps regulate our mood. And when we lose estrogen as women, that serotonin can't stick to those brain cells and help regulate our mood. Okay, I'm breaking this down just so I'll to make it in layperson's terms. And so when that happens, we tend to have mood swings, more depressive symptoms, and more anxiety. Women with HIV compared to women without HIV experience higher rates of depression and anxiety before losing the protective effects of estrogen. So, women with HIV, we have found in a couple of studies to date, do actually have a higher degree of increased depressive symptoms if they were already diagnosed with depressions before entering menopause, and increased anxiety because of this hormonal changing. And also, women at large, regardless of their HIV status, have a higher risk of developing new onset depression and anxiety upon menopause during this estrogen loss. So, for women with HIV, if you already have a known history of psychological health concerns, including depression and anxiety, it's a time to say, I might need to reconnect with my provider and adjust my medications. Attend more therapeutic groups, support groups, focus groups, get more connected with amazing organizations like the Well Project, and just being around other people who are experiencing this, because you're not going crazy. It's a hormonal underpinning, and it's something that can be addressed. Okay. So that's how I think about psychosocial things. And then lastly, when we talk about physical health, how the question is, what are the needs of women? So we also know that estrogen, that primary female sex hormone, plays an essential part in our bone health. It helps keep the glue in our bones, that I like to say, so that they're strong and they don't break easily. So when we lose estrogen, our bones become, I like to describe it as like when you're drinking through a straw with holes in it. You could still get the water, you could still get out and walking, but you just don't feel as strong. Heart health. Estrogen helps reduce inflammation and keep our heart arteries healthy. And then also cognitive function in the brain. Okay, so we think about estrogen playing a key role in helping with cognition and that sharpness, that memory, that recall, all of those things. And then if you think about it, with HIV, a lot of the research that you have been reading about or hearing about with HIV and aging, when somebody ages with HIV, we are learning that HIV itself, whether you're on medicine or not, may play a role in increasing risk for heart disease compared to people without. And there's a statistic that's known that women with HIV have up to 3 times a higher rate or chance of having a heart attack compared to women without HIV. We also know that women with HIV tend to lose bone mass or be at higher risk for what's called osteopenia and osteoporosis compared to women without HIV. And Sara and Dr. Michael Yin have done some great studies on that. And then we also have learned, and we're growing to learn, that cognition in women with HIV may, and without people with HIV in general, may experience cognitive decline earlier, potentially because of the virus. So when we overlay that as a baseline, being HIV positive and potentially experiencing some of the educational challenges, the psychosocial challenges, and the physical challenges just by living with HIV, when we as women, we rip the rug out of that estrogen at age, plus or minus 45 all the way through, there are going to be different needs with assessment, education, and psychological support. So that's why starting with a forum like today to understand, we hope by the end of this and through your thoughtful questions, we'll be able to arm you with some thoughtful questions that you can ask your provider, you can ask your peers, and start learning yourself. So that's a long answer to that question, but I just wanted to highlight those 3 key buckets, because this is what you need to remember so we can start working on your own health now, during, and after midlife.
That is critically. I learned so much just now throughout all of that. And I think what stood out for me is really highlighting the fact, because I know, and I saw someone in the chat the same thing, I think it was Griselle. I know for me, every time something new happens to my body, I'm constantly like, is it HIV? Is it just regular physiological changes? And it can be, yeah, it was Griselle. It can be very, very stressful to have to try to figure that out. So that explanation makes so much sense. And it actually, it makes me feel better about some of the things that are happening to me right now. So thank you so much for that. I think Gina has a question for us too.
I didn't.
No? Okay. All good. Um, so within that, you were talking about trauma. And trauma is a sensitive topic and also one that also gets overlooked quite a bit. So why do you think it's important for menopause to be information and care, care specifically around menopause to be delivered using a trauma-informed approach?
Sarah, do you want me to start? Or
Yeah, sure, you can start.
okay.
Since you already kind of brought that up. Yeah.
Sure. Okay. So just getting back to trauma, I mean, trauma, I'm very pleased to learn that I feel like I'm reading more about the need for trauma-informed approach to be considered an integral part of all healthcare delivery. The reason why menopause, for me and for what I have read in literature among women with and without HIV, and populations of socioeconomically disadvantaged women, is that, as healthcare providers, as clinicians, we have a lot of knowledge and experience with helping to solve problems, medical problems for folks, and to offer solutions. However, our rich perspectives, our education is only as strong as the woman's ability to hear, understand, accept, and feel comfortable having a conversation and next steps. So because the sensitivity of the topic, because menopause has a lot to do with sexual health, and the conversation not only talks about educating a woman about the female anatomy and about the hormone changes that happen, it also often includes an exam of some sort, right? A pelvic exam. And a lot of times those exams are incredibly uncomfortable for many women, and in general. And so the use of a informed approach is critical because while a provider might know the black and white foundation of knowledge on that certain topic, the way that it's delivered and received is not one size fits all. And so when we talk about menopause, when we talk about in a clinical setting, a private clinical setting, it's always important to consider the woman's history, all right, doing due diligence before that encounter and talking about a woman's history, their social history, their history of trauma, their history of medical, mental health, medical concerns, etc., so that the way the information is delivered is in a sensitive manner that will not trigger or elicit discomfort, so that the woman can continue to feel comfortable and asks questions that are pertinent, without a top-down approach or a linear approach from the provider to the woman saying, this is what it is. You lose hormone, your vagina gets dry, you blah, blah, blah. That's not, it's not being sensitive to the needs of that person. And it's not taking into consideration that this might be a difficult thing. And it's not coming in, just giving all of the information at once and then being like, do you have any questions? Here's a pamphlet. See you later. It's saying, this person, this woman in front of me right now has a very traumatic history. I'm going to start by saying, have you heard about menopause? What does that word mean to you? And then she's going to dictate and lead that conversation by saying, I know it's A, B, and C. I don't feel comfortable having this conversation right now, or I'd love to hear about this. This is what I think it is. It's just having an open dialogue. And Sarah, as a clinician, I know because you're in the clinic with women with HIV constantly. Do you want to talk a little bit about, the trauma-informed approach, what it might look like?
Yeah, sure. I think, everything that you mentioned is so important. And I think just as a provider, I think as already been said on the forum, it's so important for us to acknowledge that menopause, which marks the end of a woman's fertility, that discussions about reproductive health that can be traumatic, and to state that upfront, even, to start the conversation with patients about that and say, I understand that some of what we may talk about today is either going to be triggering or difficult to talk about. And if at some point you feel uncomfortable, we can stop. We don't have to do all of this today. I think starting with those expectations is really important. Fortunately, Gina has that approach where she's able to see it as a positive, but I think not all patients are able to see it as a positive early on. I had a patient who really struggled with menopause because she never had children, because she was diagnosed with HIV early on when we didn't know about the risks, the mother-to-child transmission risks. And so she just put off having children. And when she hit menopause, that was officially the end of her fertility, and really struggled. And so just recognizing that it can be difficult and having those open conversations is really important. I would say some of the other strategies that we try to take in the clinic when we're caring for patients is to really just have a safe environment, and to make sure that all of our staff are trained in trauma-informed care, and make sure that our patients feel comfortable at every step of the way, and to screen for that trauma. Like you said, we have to ask, because it's not something that patients should be expected to share. But if we don't ask, we're not going to know, and then we're not going to be sensitive to it when talking about anything that may trigger some of that past trauma.
Excellent. Thank you so much for that. I appreciate the sensitivity that you guys are putting forth when it comes to having the communications and these conversations with women living with HIV, because and the importance of it isn't highlighted enough. So thank you for that. It seems like there is a limited amount of data about menopause in general. Is there evidence that you can think of that's focused specifically on women living with HIV?
Yeah, I can start, and I'll have Sara jump in as well, because she's done a lot of the research that exists. There is not a lot of research specific to women with HIV, but we do have some. Most of the research focuses on how menopause presents and how the age of onset. And so studies have looked specifically at the question of, do women with HIV have earlier onset menopause than women without HIV? And what's really interesting is that the data is conflicting. So some studies say, no, women with HIV experience menopause about the same age as women without HIV. And other studies say, yes, women with HIV experience menopause earlier than women without HIV. So they're conflicting. Some of the reasons for that is that women with HIV may lose their periods at a more often, but not always due to menopause. So I think that's important for the women listening today, the women and men and physicians, anyone listening today, to know that not everyone who loses a period for 12 months has menopause, that we need to look at other reasons for menopause. It can be hormone imbalances like your thyroid, or it can be anxiety and stress and depression can lead to loss of menses, malnutrition. So many other reasons for loss of menses. And we don't want you to assume that just because you've lost your menses that you've hit menopause. And so this is an important thing to be aware of, that yes, it may occur earlier. And so if you hit menopause before that average age of 51, that it may be menopause, but it may not be. And so we want you to talk to your providers about that. The other area that we've had some research in is hot flashes. So we talked about how hot flashes really are the hallmark symptom of menopause. They're by far the most prevalent symptom, and they're the most bothersome symptom. And they have downstream effects on sleep and mood, because many of those hot flashes occur at night and they inhibit your sleep. And so we've been curious as to whether or not women with HIV have hot flashes more often, or are they more severe than women without HIV. And Sara has done some of this research, so feel free to comment. But indeed, studies do suggest that women with HIV tend to have more frequent and more severe hot flashes, and those affect everything. They affect sleep, they affect depressive symptoms, they affect ability to go to work, they affect ability to take antiretrovirals, to go to clinic visits. So they're really important to be aware that we may see more hot flashes, and then to really think about what we can do to treat those hot flashes, not just to treat them as a natural process that women just have to endure and suffer through.
Mm-hmm. And yes, and building on what Sara just said, the hot flash piece in studies looking at women with and without HIV, there has been data that suggests, like Sara said, that women with HIV experience more frequent, severe, and distressful hot flashes with greater interference in activities of daily living and quality of life compared to matched women without HIV. And there have also been some studies in larger cohorts that have found an association with increased hot flash frequency and leading to or predicting more depressive symptoms in women with HIV compared to women without HIV. And they're beginning to look a lot also at, do hot flashes have a greater degree of interference with cognitive function? And is that worse in women with HIV and women without HIV? So hot flashes seem to be one key symptom in the literature so far that tend to be worse in women with HIV compared to women without. However, like Sara said, there's a lot of factors that have influenced the outcomes of these studies, particularly making sure that the women who are entering them are in true menopause versus experiencing a lack of a period because of another medical reason. And then also a lot of the recording of hot flashes in these studies is subjective, meaning like, somebody asks you, how many hot flashes have you had in the last 24 hours and how bad were they? Well, the way that we're getting around this is there's actually now monitors that people are wearing during research studies so that they're collecting that information, like how many hot flashes have you had, how bad were they? And while they're wearing this monitor, we can really see, are they experiencing a hot flash as frequent as they say? And so that's going to be really important. And then I'll just conclude by saying that we know, like I mentioned, there have been some studies done by people in my research group at Mass General and others that have now shown that women with HIV during menopause may experience a greater risk for what's called subclinical heart disease compared to women without. And what I mean by subclinical heart disease, meaning when you have a ultrasound of the arteries in your neck or an MRI of the heart, they have noticed that women with HIV during menopause may have an increased risk of what's called plaque. That's kind of that gooey, like jello from bad cholesterol that can line the arteries. And it's called non-calcified plaque because it might break off and travel someplace else. But research studies have shown that women with HIV during menopause might have an increased prevalence of that plaque in their artery compared to age, race, and weight matched women without HIV during menopause also. So it's just, taking this information together, it's alerting primary care providers, infectious disease providers, women health providers, that if in fact women with HIV are entering menopause earlier, having more burdensome symptoms, including mental health, mood, and hot flashes, and increased risk for heart disease, that conversation needs to happen way earlier than the age of 45 and intervened and continued throughout midlife or age 50. The average age of menopause in women without HIV is about 51 years old. And like Sara mentioned, the data has been conflicting with women with HIV, with some studies saying that women with HIV may enter menopause as early as the age of 45. But then many others have shown that they enter menopause around the same time. But since, looking back on an earlier part of our conversation, women with HIV, people with HIV, and particularly women may be at risk for some of these other overlapping illnesses because of the HIV that might get worse with estrogen loss. what are we waiting for? Let's start with the lifestyle education. Let's start with the mental health support, the trauma support, the cardiovascular screening, the bone screening. These are all guidelines that should be considered, because we're going to all get to menopause at some point, and it's easier to fix something earlier than to say, oh, shoot, now you're in menopause. We're in a pickle here. We're undo a lot of things. So, that's just a consideration.
Definitely. And I think I'll have a question a little bit later about as it relates to like the age stuff when it comes to age stuff with menopause. Miss Gina Brown, do you have a question? You're muted.
I knew that would eventually get me, y'all. What should women living with HIV know about hormone replacement therapy?
That's a good one.
Sara B, you want to start with that?
I can start with that, sure. So hormone replacement therapy, now more commonly called hormone therapy or menopausal hormone therapy, is really important to know about. It's a broad term. It's used to describe both the unopposed estrogen use, right? So we lose estrogen when we hit menopause, and so it's providing estrogen, and we can give it estrogen alone for people who've had a hysterectomy who don't have a uterus, because we don't have to worry about the side effects of estrogen. Or it's giving estrogen plus progestin to people with an intact uterus to prevent the estrogen associated, what we call the sort of growth of the uterus lining. And so it's available in a lot of formulations. So just like now antiretrovirals are available either as oral or injectable, hormone therapy is available either as oral or patch, just like oral contraceptives, or as a gel. And so can be administered in a number of different ways. And it's the first line treatment for women who are in that menopause transition or very early after menopause, who have hot flashes that are frequent or severe enough to affect sleep, quality of life, ability to function, or and who are within 10 years of menopause. So, hormone therapy got a little bit of a bad reputation years ago when there was some data to suggest that there was an increased risk of cardiovascular disease in women who received menopausal hormone therapy. But this was when we looked at the data, when the researchers parse out the data in a much more clean way to look at women who were in early postmenopause, so within 10 years of that last period, it actually found that it was beneficial. So it was protective against cardiovascular disease. So all this fear of giving hormone therapy because we're worried about the cardiovascular risk has actually been reversed. Now, there are still some risks of menopausal hormone therapy. It's not right for people who have had breast cancer or who've had endometrial cancer. And so it's important to be aware of it, but to talk to your provider and see if you're a good candidate for it, because although it has been shown to be very effective and safe in certain populations, it's not right for everyone.
So with that being said, we're in a time now where people are looking for other alternatives, right, to taking medications every single day. And I know for me as a woman taking medication every single day, the more that I can cut out or do alternatively makes sense to me. So are there widely accepted alternatives for hormone therapy?
Yes, I can answer this question. So there is a organization in it's in the United States, but there is international representation called the North American Menopause Society. It actually just changed its name to the Menopause Society, and they really are. You could Google the Menopause Society. It's an interprofessional group of providers and researchers, and they really do a thorough and amazing job at setting the tone and the gold standard for the guidelines for the treatment of menopause. And they are very welcoming and eager. I'm a member of the organization to learn more about HIV and menopause and HIV, and how we can adapt our guidelines for this population. I give you that as a background because they just issued, and I can email it to Bridgette to share with the group after, a guidelines on non-hormonal interventions for the treatment of menopause symptoms, recognizing that A, not everybody wants to take a pill, and B, not everybody can health from a health perspective and a health history perspective qualify to take the many options. So starting with the non-pill forms, okay, when they looked at acupuncture, when they looked at exercise, when they looked at something called cognitive behavioral therapy or CBT, and then also mindfulness meditation, none of those things can hurt. Okay. None of those things, particularly exercise, diet, having more soy in your diet, exercising routinely through doing yoga, acupuncture, none of those things can hurt. But in head to head studies, when they look at very rigorous outcomes, they weren't shown when compared to medication interventions to give any profound benefit, meaning reducing the amount of hot flashes by a certain threshold. But that shouldn't be a message to say that you shouldn't engage in those behaviors, because there are some women who feel much better after having acupuncture. I have many women that I work with in the research setting, in the community setting, that swear by acupuncture as a way to help reduce their hot flashes or their stress. The same with mindfulness and deep breathing, and the same with exercise. And then there are some people that say these things didn't work for me at all. The only non medication, when conducting that very rigorous head to head review of literature, that showed promise was, in fact, cognitive behavioral therapy or CBT. And this is something that you work directly with a psychologist or a psychiatrist. It's an intense, program that you can work with. And they essentially have like 1 hour sessions. I think the time can vary, where you do some cognitive exercises to be able to thoughtfully think about the experience of having a hot flash. And then instead of mentally going into a negative state that might be reflective of your body, um, they can do some programming together with you so that you can say, I'm having a hot flash. I know why this is happening to me. I'm going to start doing, thinking about this in a different way so it might not affect me. Now, what I'm sharing you with right now is not cookie cutter to what's done in every CBT session, but I'm just trying to give you an example of what cognitive behavior. It's exercises for your brain to help reduce a symptom. And that was the only non-medication intervention that seemed to show in these head-to-head trials benefit with moving the needle with some of the symptoms. But as a backdrop, I will say it doesn't mean you shouldn't do yoga, you shouldn't do acupuncture, those things cannot hurt. Okay. The other camp is hormones. Like Sara mentioned, there are some people who might not be a candidate because of their medical history for taking a hormone. Okay. And there are actually categories of medications that have been shown to have benefit at reducing hot flashes in particular, and in some case, mood instability. And those include the medications that fall under the medicine category of SSRIs, serotonin, selective serotonin reuptake inhibitors. Okay. And that is, I have to be careful here not to use the wrong names. That is your escitalopram, your paroxetine. Sara, am I doing a good job with this? I'm trying to like not say brand names, but if you Google, you would know what I'm talking about. So the reason why these tend to work in a lot of women is because, remember I told you that estrogen is like a Velcro to the serotonin to hold it in your brain. These medicines are like a bus that drives serotonin into those cells. So that's why they can help work with mood stability, but also hot flashes. Okay. The other is the gabapentinoids. Some women have been found relief with gabapentin, and taking at night may also help with sleep. Okay, which is very interesting. And then another popular one that has been shown is a new class of medication called KNDY inhibitors, CANDY inhibitors. And this is just released. There is a FDA approved medicine that is now on the market that targets that particular hormone, that candy hormone, and blocks it, and it somehow blocks hot flashes. One of the side effects of that, it's brand new. People are using it. The preclinical trials that have been done, I don't know if there's been any done in women with HIV, or I'm assuming that the group of women that these drugs were tested on, I don't know if they had to reveal their HIV status, but if they're probably a very small percentage of women with HIV, maybe in those trials. So the only thing that they monitor is liver function. And so we have not yet had a trial of this in women with HIV. And I do believe we need to see more specifically in women who are co-infected with hepatitis C or have any other form of liver disease, whether this would be safe. And then also just paying careful attention to the use of this category, this medicine, in women who are on antiretroviral therapy that may be broken down or metabolized in the liver. So that means that, I'm not saying that this wouldn't be an option for some women with HIV, but because it's brand new, we just need to look at this more carefully. So there are options, that are approved or not. And I'm just going to use this opportunity as a plug to also be very careful with bioidentical hormones. Okay. Right now, these bioidentical hormones that we see on TV, I don't know if are like me. I like to watch a little Lifetime sometimes. I like to watch a little Bravo. And it seems to me that the commercials that come on sometimes are targeting, oh, are you experiencing menopause? You can pay $1,500 for a 30-day supply of this magic vitamin/herb that will get rid of your hot flashes, improve your sex drive, make you lose weight, make you be, the best version of yourself. And you write your check and you hand it in, and none of these have been regulated through the FDA. So what that means is that they haven't been tested for safety, for efficacy, but they can be cleared as a non-medicine intervention for menopause and sold in Walgreens and other pharmaceutical places or available online. I caution you, please, please, please do not buy those. And if you're interested, have a very thorough and direct conversation with your healthcare provider to make sure they're safe for you. That's all.
That was amazing. Thank y'all both for that. I was sitting here just like soaking it all up. I was like, oh, I'm going to do this. I'm going to do that. I already do the thing with when I'm having a hot flash, and some of you who may have gone through it already or gone through it may do the same thing. I imagine myself on the Swiss Alps, and I think that I'm out there with a bikini on in the snow. And sometimes it works, sometimes it doesn't, but I still do it.
Yeah, absolutely. And dressing in layers and using fans and regulating temperature and all of those things are 100%. I have a friend who sleeps with a bag of frozen peas under her pillow and then flips the pillow in the middle of the night. All of these things are effective, and taking a shower before bed, yeah.
Yeah. I was at the Pink concert earlier this summer and it was 100 degrees, but everyone still went out. And there are these new devices that are like you can wrap around your neck that are cooling, that you can sort of charge, and lots of new devices too that are not medication that will still provide relief. I love the imagery though, Gina. That's beautiful.
Yes. So, how can women talk to their providers about menopause? And what questions should we ask?
You want to start with that, Sara?
Sure. I think it's important to bring it up. So although, there are more and more menopause societies and guidelines recommending that providers ask specifically about symptoms because patients may not share, I think not every provider will ask. I think it's particularly in HIV where in this country, the most patients with HIV are men. They still make up the majority. And so just by the bias of experience, providers may have a little less experience screening for and caring for people going through menopause transition. And so I think bring it up. If you're having any concerns, any questions, any symptoms, ask your provider. Tell your provider about them and ask if they think they may be due to menopause. ask if they think you would be a candidate for treatment. And if they don't know, it's okay to seek a second opinion. I think it's okay to recognize that not all providers who are HIV providers will feel comfortable or knowledgeable providing menopausal hormone therapy or menopausal non-hormonal therapy. And so it's okay to ask for a women's health provider if the provider you see for HIV isn't experienced in menopause. We're working really hard to get education out there, and this is the first step, the work that the Well Project is doing, but I would just encourage you to advocate for yourself and ask.
Yes, I agree. And just to piggyback on that, that was very comprehensive and very true. You go to the doctor and they're almost always doing blood work, or, when you go to visit, right? And so it's always a good time if they're like, oh, we're going to check your cholesterol, to bring up menopause every time. Because sometimes you go in with your own list. I always encourage everyone to always bring a list, whether it's typed in your phone or a piece of paper, because the visit's short and you want to make sure you get your questions answered. And so, you're like, "Wait, oh, yeah, you're checking my cholesterol levels today." That's right. I'm experiencing hot flashes. Is there something? I think that might be menopause. Is there something else we should be doing to look at my heart? Or now that you're checking my heart, what about my bones? Or, these are the questions that I think are really important. I also think that's from a health perspective. So every opportunity is an opportunity, and we as women are going to have the right. And as you're learning with this overlap between HIV and aging and menopause and, just being at midlife, estrogen loss, it's always an opportunity to say, hey, I think I might be going with menopause. I went to this session and I heard I should be asking about my heart, my bones, and my mood. What should I know about that? And just like Sara said, starting the conversation. The other thing that I think is really important, and I cannot emphasize enough, is this mental health piece. Okay. Life is not easy every day. Okay. And the pandemic has not, meaning the COVID pandemic, has not done any favors. And I think we, at large, as a country, are and internationally having the biggest challenges with facing the biggest mental health challenges. Even folks that you would think were the strongest folks on earth, in your circles, everybody is suffering a little bit. And so if we know that as women losing estrogen, particularly during that time where there's a fluctuating right before you stop your period, if you notice, you're not well and you're not yourself, and if somebody says you're not yourself, listen to that and go to your doctor, come to your communities like this and say, I'm not myself and I don't know what, because there's something that can be done. And, the estrogen loss is real. And we know the biology of that to the brain is real. So whether you need to start medicine or start some form of alternative therapy in the community, one-on-one, or tweak your existing regimen, that's really critical, because getting that foundation at the cusp of that menopause transition will allow you to build strength. Do you know what I mean? As you're encountering it. And second to that, I have had known women in my community at the hospital here, who have a history of substance use disorder, who have relapsed during menopause because their mood and their sleeping and the sweats, and they can't take it and they get vulnerable and they find no way out of this cycle. When you don't sleep, it can really destroy a lot of other processes. So, if you are a person with a history of substance use disorder, menopause can be, this is anecdotally, I find in my population, in the community that I work alongside of, can be a very precarious time of instability. I see somebody, Gina, I used to cry at Tide commercials. Yes, that's true, right? I cry at the holiday commercials. They're already starting to come out now, but you know what I mean? And if you're feeling low, the downstream implications of a hot flash or a poor night's sleep in a series of days can be profound. So mental health, any kind of behavioral health challenge you might have experienced, check in with yourself, check in with your friends, and have them reach out and get help.
Thank you for bringing up mental health. It is critical, and we're at such a low space for mental health right now, with people's access to it and ability to get to it. I think it's always critical every chance we get to mention how important it is. I just wish we had better solutions for how to, get more people to it. We're getting close to time, but I think this is really important to bring up because often our lifetime survivors, the folks that were born with HIV or acquired HIV very early on in life, get left out of conversations. And I want to make sure that I address this question for them, which is, I know we talked earlier about the fact that, there's conflicting data on whether or not women with HIV start having menopausal symptoms early. But for these folks who have been living with HIV for their entire life, do you know of any information that suggests that they should be getting screened earlier, or that this is something that happens to them earlier than it does for like folks like myself who acquired HIV at 40?
This is a very interesting question. I do not know of any literature to date specifically among lifetime HIV, women living with HIV for their lifetime, and early onset of menopause or menses. I don't know if you know that data, Sarah. I don't know that data. Meaning the start of their period. Um, I in that population, I have to put a pause in that because I think it's very interesting, and I think we could get an answer if a lot of times we look at menopause, age of onset of menopause, physiologically may have to do with the age that you were when you started your first period, and also when you were pregnant, the number of pregnancies that you've had, et cetera. There's correlations. And then lastly, there has been work that has shown that a woman encounters menopause around the same age as her mother, when her mother encountered menopause. But whether or not that's influenced by lifetime HIV, I don't know the answer to that. And I think that's a really good question I'm going to look into. And if we find answers, we can get back. In terms of the question is, does the age of which we acquire HIV affect the age that we get menopause? I don't know if distinctly anyone has done a study that said if you contracted HIV at age 40 and older, then you're more likely to start menopause later. If you got it before the age 40, you might get at it earlier. The work on onset of menopause in women with HIV to date has not gotten that granular yet. I think we're still trying to determine, and based on what Sarah shared with us earlier, it could very well be multifactorial and have to do with your own personal history of specific medication use, body weight, the degree of poor immune health or your lowest CD4 cell count, your highest viral load might influence your menstrual patterns. The use of methadone can influence menstrual patterns. AIDS wasting syndrome, history of AIDS wasting syndrome can influence menstrual patterns. And then lastly, I was just going to think of something else in HIV that might influence menstrual patterns, just escaped my mind. Oh, PCOS, which is polycystic ovarian syndrome. So a history of that can often influence onset of a woman's period from a metabolic standpoint too. So it could be multifactorial about whether or not age of diagnosis affects age of onset of menopause, and we don't know the answer to that. But I really think looking at lifetime HIV and menstrual patterns is something that is a very interesting question.
Definitely a fair answer, and I appreciate it. I feel like the more that we put things out there, the more it makes people look at them and maybe want to get into kind of taking a look at it more. So definitely. Thank you. And thank you. It's a thorough answer and it's a fair answer. So I appreciate that very much. We are almost out of time. I just want to give an opportunity for each of you, 30, 40 seconds. If there's something interesting in research that's coming up that you know about, or something that you just want to put out.
Go ahead,
Sarah B, you
Sarah.
want to go first?
Sure, I can. We're a little biased, but this is as you can tell by what we've shared today, this is an area that we're really passionate about. We want to improve the lives of women who are aging with HIV, women who are going through menopause. And so Sara and I are actually working together with a colleague, Michael Yin, and we are working on a study that's going to be a randomized trial looking at hormone therapy and whether or not it works and is it safe in women with HIV. And I'm most excited about that study. I think, we talked about how hormone therapy is the first line treatment for hot flashes, but women with HIV were excluded from those studies. And so we need data, and we need it now, about whether or not hormone therapy works for women with HIV. And so we're working together, and that study should be launching next year. So very excited.
Mm-hmm. And hopefully answering a lot of the questions that were proposed today. And I would just say, keep up the good work. Keep asking for answers. Keep challenging your providers. Keep coming to groups like this. Staying connected and using each other as much as possible for resources and support. This is the only way we're going to continue to advance this agenda forward for women with HIV worldwide. And so on behalf of Sara and I, we are so grateful to have the opportunity to be in this forum. And please don't hesitate to reach out to us individually or through the Well Project if we can ever be of assistance to you.
Gina Brown.
Thank you, Bridgette. Thank you, Sara and Sara. Thank you, Well Project, for doing this. Thank y'all for hearing us as we talk about aging with HIV and the challenge of menopause, something we don't talk about, but we're starting to talk about. And I'm just so happy today. I really am. So thank you.
Well, I want to add my thanks to you. I want to encourage everyone watching, please click on the link in the chat and take our survey that we have based on our call today, our chat today. We really, really appreciate it. The feedback helps us with our programming. It helps us move forward. It helps us continue to address the issues that are affecting women with HIV. And I am so grateful. I learned so much in such a short period of time. And I am incredibly grateful that you were here and that you took the time to do this for us. So thank you so much. And to everyone out there, thank you for joining us, and we will see you next time.